Director of Northeastern Indira Gandhi Regional Institute of Health and Medical Sciences, Professor Dr. Nalin Mehta, habakran mat kinong tho khubor ula pensyai ba kaklem don kano jingleh torti na kinong sumar ya ka weik samla bat kila ay ka jing sumar ka bapiang tam na ka benta jongka. Dr. Mehta ula penpaw ya ka jing ngau khia halor ka jing sya kano le torti bat bom sut nyau kinong sumar ka hospital ya ka weik ka samla nongpang ka bala khlad no dangshen. Laban kedau bagi Dr. Negligence kala sya kano ba kadon ki jingleh torti ha ka baidai mat ki jing sumar ka samla ranishas imli ar place nyam karta bat ka bala khlad no na ka ni kasla pertai ha baidai ber ki jing sitam ba ka teik samla kala yo Dr. Mehta ula pensyai ba ka teik samla ka bala khlad kaladon ki jingpang tuberculosis lani TB bat kaladon ki jingwit haki benta jong ka snier bat namar kata ladon kam ban pu yaka. Hadin kata Dr. Mehta uloong balarano ekasha ICU bat kaladon ke jingtot akur komring mensem namar kaladon ke jinglang hakitor uloong bamar kumta ke Dr. Kelapan ke jing menjur na kabenta pentep yo pipe na sentur banirap hakaban ring mensem hanrai ki klem ai ke jing menjur nolor kata ulai thuru baknik samla kadon ru ya ke jingpang hau klong snam bat ke deiru ke belasya sumar teng hakni ke hospital house nem arajar khat nyau. Dr. Mehta uloong baki huri hura kilami namar badona pedeng ki bahayeng ki klem sngotu bha ya ki jingpang jingstam ba ka teik samla kadon. Shushu nagaleng Dr. Mehta uloong ba sngotu bagi nongpang kim sngotenat ban ap ban yo jing sumar bad ya kani kaliyo jing ujor labunsen hanrai nagaleng knong sumar kimla ban pelot ya baro ki nongpang shisin peng. Uloong ru bagi nongpang ki don hok bandom hanrai ki Dr. Kimla ban shuai jing sumar jendat klem dapet benia ya jingpang bat ki hospital ki doni ki kandon ba ki dai ban bot sha ba kin ai kano ki jing sumar.
Gone through the details that have come out in the press, and it is unfortunate that press at times utilizes some words which are very, very strong. Negligence basically is defined as something, medical negligence, where somebody does something which nobody normally would do, which is not true. Here, in fact, I have with me my head of the Department of Surgery, who is currently officiating as the medical superintendent, also with some details. But we had a very sick patient who had multi-drug resistant tuberculosis. She was admitted with us, she was investigated, and she had obstruction. She was not passing through intestinal obstruction. And normally when the obstruction is for a long time, surgical intervention is required. So after the investigation was done, the surgeons were consulted and they suggested surgery. Initially the patient refused. The next day the patient agreed to undergo surgery. And this surgery, because the patient is very sick, is basically not very extensive. It just bypasses the obstruction, temporary relief from the obstruction, so that when the patient recovers, later on extensive surgery may be undertaken. In the meantime, because of probably the drugs that she was taking, there was liver damage. Post-surgery, she was admitted in the ICU. She had difficulty in breathing. The doctors wanted consent for intubation. Intubation is where a tube is put to help in breathing. She refused. The next day, when her condition worsened, she agreed for intubation. Intubation was done. There was trouble breathing because she had, like they say, water in the lungs. She is a known heart patient also. She had heart treatment earlier, maybe in 2017, if I'm not mistaken. And eventually the patient succumbed. And the controversy erupted probably because some of the relatives of the patients were not very clear about the details, or they did not understand the technical details that were explained by the doctors. So that probably is one of the issues. Beyond that, I am not aware of how the newspaper reported negligence, because every investigation and the standard treatment that is given to such patients was given by negligence. I will request my colleague, Professor Noor Topno, who is head of the Department of Surgery and officiating medical superintendent today, to give you a few details, or if you have any questions, he may give you the answers.
My director main. After the operation, the condition of the patient was not very good. So because of the condition not being very good, the patient was shifted to the main ICU. We have multiple ICUs. So this main ICU is the one which is one of the best that we have around here, and that is managed by the anesthetist. So patient was kept there from 17th up to 20th. When the condition of the patient became little better, the patient was shifted down to the other ICU, which is a little lesser ICU, that is called the surgical ICU. Usually we keep all those post-op patients and sick surgery cases over there. Over there, if they become better, they go to the ward. If they become worse, they go back to the ICU. So that was the condition of the patient. So till 21st, patient was more or less okay. But the next day, on 22nd, she had this breathing difficulty. And that was probably because of accumulation of fluid in the lungs. And also there was extensive damage to the lungs because of the earlier tuberculosis that she had. So by the time they are MDR, before MDR they are taking usually the other normal drugs, and then they have been taking other drugs also, which is for multi-drug resistance tuberculosis. Okay, so unfortunately the general condition of the patient was quite bad. And there was one more thing, we had planned to give her 5 days of albumin. That's an injection that helps reduce the collection of fluid in the body. Okay, unfortunately because we lost the patient, we could not do all that. And the rest I think has been well dealt with by my director. If you have any questions, I can answer. Many a times is there is actually a difference in perception. Now the patient, what I understand was, patient was complaining that she is not able to breathe. Okay, but at that time patient had refused intubation, but she was being given oxygen by mask. Now one of the things I got to understand was patient did not see any oxygen cylinder. But here in the ICU we have actually the gas, we have gas pipelines, and it comes through basically pipeline, the gas. So it is very, very improbable that in a patient who is as sick as that, we would not be giving oxygen. So I don't know, I think this is probably a misconception somewhere.
So can you also make us clear anything?
I can, as a surgery person who's been there more than 35 years in this profession, I can give you a general outline as to what we do. And what has transpired between the doctor and the patient, I won't know unless I really ask them or somebody gives me that information. Generally what happens is, I don't think any further operation from surgery part would have been required, because like initially we told, a patient whose condition is very bad, we don't try to do the full surgery at that time. We do just enough. Like supposing there's a road which has got multiple potholes and very badly damaged. At most what we do is we provide a bypass. We do the repair later. So in this condition, same thing. Once the general condition becomes better, then only we are going to do the full surgery. You know? So I don't know what has transpired, so I cannot really comment on that part. But the approach usually is this. So from surgery side, I don't think any further operation would have been contemplated. Yeah.
So
I'll give you the example of, supposing there's a, now this was what is called as intestinal obstruction. By intestinal obstruction, what we mean is, in the intestine, because of tuberculosis, there is total constriction like this. And food and other things don't go down. And that was the complaint of the patient. So once we did the CT, we knew exactly what is the problem and where the problem was. Okay. So the operation ideally would be to take out the whole area which is causing obstruction. That means you do a much bigger operation. But in this patient, that kind of operation is not very good because of the general condition of the patient. So what we did is what is called as a bypass. Suppose this is the intestine coming and this is where the block is.
so just keep it.
Yeah. Supposing this is where the block is, right? So what we do is we make an opening in the intestine here, and that opening is brought out here, so that whatever food particles which are held up over there can actually come out. Okay, I hope I'm clear enough.
So that was the surgery.
That was the surgery. So surgery which was done was a minimum surgery, just done enough to make sure that the patient lives. And if the patient lives and becomes little better, with the better general condition, we can go in for a larger surgery.
So can you say
Incision, that when we to get into the abdomen, we have to make an incision. Okay, so the incision usually will be at least about this long to get into the abdomen. So the how big a surgery is not dictated by the length of the incision. Okay, sometimes we may do a very small surgery. In this case, the surgery was not a very big surgery, but you have to give an incision big enough to go in. Laparoscopy is not an option in this case. Laparoscopy is the one where you use small incisions to get into the abdomen. Huh?
So,
Progression, as we call it. Once the general, see, when the patient came to us, also the general condition was not like a normal person. When we operate in a normal person, we can predict how he or she will behave. And usually, if a normal, healthy person is operated for some accident or something, these patients do well. But a patient who's having something like a major disease, like multi-drug resistance tuberculosis, the general condition of the patient is very bad. Okay, so in such patients, the outcome is very poor, actually, so to say. And that is the reason why we didn't do the full surgery, but we did just enough to help patient live longer. Okay, so there are multiple factors. Like one of the things that we noticed was previously in the past, probably again because of tuberculosis, she had a condition which is called as constrictive pericarditis. For that, she had undergone one major operation in the heart. Okay, then she also, because the drugs she was taking, she had some effect on the sorry, not the kidney, it was on the liver. So because the liver function was not good, what was also happening is her albumin was very less. And because the albumin being very less, the problem what happens is they lose water into the body tissues. And that is what causes this kind of pulmonary edema. And that is what was the major problem in this patient. So, dominant effect, let me put it this way. How one patient behaves with tuberculosis and another person behaves is very different. Okay, some people do very well with treatment. Some people, despite treatment, the earlier damage which was done because of the disease is so severe that it compromises to the patient to a large extent. And especially MDR tuberculosis, which is a severe form of tuberculosis, these patients, once they become okay with treatment also, their ability to breathe is compromised. Okay, that is usually the problem. It's not that once you have suffered from tuberculosis, after that you are absolutely okay. In some, yes, in some, no.
Person who is in charge on that day.
No, we are
regards to
going
this.
to have an internal, we call it as an audit whenever we have this kind of death and all that, where there is, I won't say any media related issue, but we have our own internal quality check. So we'll be instituting an audit or a sort of audit inquiry into this to see if there are any areas where we may have gone wrong, where we can improve. This is a continuous process.
so I have one more question.
That area. Now what happens is, when you get admitted to a hospital, when you get discharged, there's a discharge report that is given to you, which is quite an extensive but a concise report which tells everything about the patient, what was done and what not. When the patient dies, we don't generally give the whole written report like that. Okay, we usually give what is called as form number 4, which is a government requirement. So in case the patient has died, the cause of death is written in that, and what time patient died, age and other demographic details are usually there in that. After that, the actual death report comes. Okay, and at any time if the patient wants any extra information, all they need to do is write a letter to the medical superintendent and we'll provide the necessary information. It's that. Okay.
To their records and reports. Most patients, when they are discharged, they are given a discharge summary. The discharge summary very clearly mentions what time and on which date the patient was admitted, what was the problem for which the patient was admitted, and gives a brief of the treatment and the advice following discharge what all medication the patient should take. And if we lose a patient, a death certificate is given. To my mind, a patient who's been admitted for a week, 10 days may have 30, 40, 50, anywhere from 10, 15 to 30, 40 sheets. Various investigations, daily temperature and blood pressure and respiration charting. So that entire patient data is not given to the patient. Those records are held in our medical records department. And if the patient requires, on a written request, those reports are made available to the patient. It is their right to have them. But our medical record has to maintain the patient record for a stipulated number of years by law. So medical records are available. If a patient or patients on patient authority, somebody requires them, they are made available to the patient. We don't have anything to hide.
You just need to.
Became a bit of a controversy because of lack of understanding by the patient. The patient did not see an oxygen cylinder. They thought oxygen will be given by a cylinder. We don't give oxygen by a cylinder. Every bed has an oxygen and vacuum port from which oxygen is given. We have a centralized oxygen, delivery system.
So speaking of
Yeah, you said you
misconception,
wanted one. This entire region, Negligence is probably the best hospital which provides quality service, and for majority of the patients, the service is free of cost. Most of them who are taking the government health insurance schemes, etc.
then what could be the reason?
Complain, I can't stop them. And people complain when they have to wait for a while. If there are 10 patients and somebody is waiting, they get upset, they get angry, they make noise. I mean, you have to come. I can't look at 10 patients in one go. I have to go one by one. So patients are dissatisfied, and it is understandable. A patient who is serious, they have an attendant, the attendant feels everything should be done within seconds, which is not possible. And the patient may be serious, but it's not that there is imminent danger to the patient's life. There are protocols and there are procedures to be followed, which people don't understand. And people are very demanding at times. They feel that things should be done in seconds. So probably that is one reason why they are a little dissatisfied. But when it comes to the current medical healthcare delivery and the way people react to it, this is becoming a very common phenomenon. I don't see any negligence on the part of the treating physicians and surgeons in this case. Whatever was required, investigated, and treatment was initiated. The patient had a heart problem, the patient had multi-drug resistant tuberculosis, because of which she went into obstruction. And subsequently, the liver also packed up, probably because of the drugs that she had been taken over a long time for the tuberculosis. We do our best to serve the people of the region and beyond. And I can't stop people from finding faults. Like for in this case, when the piped oxygen is given, the patient feels oxygen is not being given because of lack of understanding on the patient's part. Now these are misconceptions that I can't clear for hundreds and thousands of patients who come to my hospital. But I have very clearly and periodically interacted with my staff and told them to be courteous to the patients and explain to the patient what the patients need to understand. There are times, however, when there are things that are a little technical and the patient attendants do not understand that. And I will not deny that there are times I may fail to explain something to you in very simple language, something which is technical. I may not get the words to give it in very simple language. So there are times that there is a miscommunication or lack of complete communication, but we are working towards that.
See cases coming to the emergency which require operation. Many a times we tell the patient and the patient party that, look here, your problem needs to be treated and the treatment here will be operation, an emergency one. Many a times what happens is patients wait for either the mother to come or the uncle to come and give the consent. Anybody who is above 18 years of age and his mentation is okay, such a person can give consent for his or her treatment. But here unfortunately what happens is patients keep waiting because somebody elder has to come and give the consent. So this is also one unique problem where I'm sure you people from the media can also help us in this regard. Make people aware of their own rights, that they need not wait for somebody else, senior, to come and give consent. We do understand the role of an uncle here is very, very important. But I think in a life-threatening situation, some of the niceties we can overlook. No? At least if the patient is willing for the surgery and surgery is really required, that is the best way we can save lives. So many a times this also becomes a point of misunderstanding between us and the patient parties. This I'm quoting one example. And there may be instances where the doctors may be wrong. We are also humans. But nobody does any act which can lead to death of a patient willingly.